Good evening, everyone. It's really a pleasure to be back for the second webinar organized by Adhesive. It's been a pleasure to be with you last week, and I look very much forward to this second module, which is on direct posterior restorations. Hope the sound is okay. Check the sound. If everybody can hear me well, then we go ahead. So I'm talking from Geneva, the Geneva Smile Center, which is located in the west part of Switzerland. This is the view which we have in front of our practice. And for those of you who might have not been with us last week, just to give you a few words of information about my professional activities. I'm first dental practitioner in a group clinic that we run together with my brother and many other friends and colleagues, Viviana from Argentina, Alessandro from Italy, Roma from France, and Massimo from Italy. So we are first of all a group of friends, and it is a privilege and pleasure to work with such outstanding colleagues and practitioners. Next to treating patients, my other activity and second professional love is teaching. We have an education center located below the clinic, and you have seen the lecture room and here the handsome room. And unfortunately, we cannot teach anything practical tonight, but we'll try to be to cover the same topics as we have in our courses, and to be both theoretical, conceptual, but also as practical as possible. So I would like to welcome you to this update on adhesive posterior restorations. It's going to be about revisiting and updating treatment protocols, especially to answer some questions that you might have about direct bonding in 2020. When we think about the direct option, there are some key issues. The first one is to understand where we come from. Which progress, what has changed over the last decades to bring us to where we are by today? Which material then will be the best? Is it a traditional composite system or maybe bulk filling composite technology? What do we know from the literature and the application of those materials? And the third question, which I believe is of importance tonight, is which clinical protocol for which decay extent and geometry. So I will try in the next hour or so to cover those three different topics. So let's go back to a couple of decades before. You see me in 1985. I was a young graduated dentist, and I fell in love with all the different options we had in terms of adhesive dentistry already back to the mid-80s. So I was trying everything that we could get at university, and it was really a good period for brainstorming and to finding new ideas for the clinical application of those new restorative materials, because direct composites used on particle teeth was really something new in the early 80s. So one of the first ideas which I had was to move from filling up a cavity and then use burrs to create the anatomy to sculpting. And this idea of sculpting came, of course, from the amalgam, because we were doing amalgam with nice anatomy. And these images here are images which I've created during my very first seminar given to our department in 1985. Since we didn't have any effect shades in those days, I was using stains for ceramic restorations, which I mixed with modeling resin. They are not the brands which I used in the 1985, but this is similar materials. And I had the idea to sculpt with the Peter Thomas number 3 instrument, which I have shaved and made a little bit sharper. And I started to freehand sculpt composite restorations before light curing them in order to save chairside time and in order to reduce the stress, the mechanical stress, which we create on margins during finishing and correction of occlusion. And in those days, the very first material that I used for that was the Ercolite XR from Kerr, which was the very first microhybrid composite on the market. And you see here some restorations I did in the mouth of patients. Now this is the Boston view in 2017, which is actually 30 years after placement. Why am I showing this? Actually, it's 32 years, if that would show. I'm sorry, you know, it is the beauty of the live. I mean, maybe to let the text to appear on its own. Why is it interesting to look at restorations which we made 32 years before? First, because we felt that only amalgam and gold could last over a couple of decades with no problem. And also you might have the impression that new technologies are a lot better in regard to mechanics and wear resistance. Modern composites are much better in terms of shading and some properties, but we already know how to produce long-lasting restorations in 30 years. So modern technologies might not bring such a great advantage over classical technologies when it comes to longevity. Just the first important information for you to keep in mind throughout the presentation. So I started and I made my doctoral dissertation on the use of direct composite for class 1 and 2 restorations. And I developed really a profound attraction, interest, and love for adhesive restorations. And in 1997, together with my PhD brother, Roberto Spreafico, we published that book, which was really about the clinical application of all sorts of adhesive restorations on polyurethane, direct, semi-direct, CAD/CAM already in those days, and indirect. You see here some case which we did 23 years ago when we published the book, doing the sculpting, using this technique, which has been republished lately, using little pieces of composite to develop the anatomy. Some people present it as it would be new. We did it already more than 25 years ago. Chairside inlays and onlays with a technique that we don't use so much anymore. This is called the semi-direct extraoral technique. But we had already ways to restore larger cavities in order to minimize the issue of polymerization shrinkage. And this is here 21 years of clinical service. Just composite, regular composite, which we used more than 20 years ago. We could do inlays and onlays, which did perform very well over more than 20 years. In 2000, I provided clinical documentations to a company that had developed a new composite system. This product was launched in 2000, so those are the pictures in this brochure published in 2000. It was very typical in those days to replace amalgams with direct bonding. Those are what we call medium-sized cavities, perfect indication for direct. Using nearly the same protocol that I will describe a little bit later, using combination of dentine for the depth of the cavity and enamel for the surface, even some effect shades underneath the last enamel surface. That was done in the time of the launch of this product. So you can have the proof that I'm not lying with the longevity of those restorations. And now they are seen here nearly 20 years after placement. You see that the form, the anatomy has not changed. The adaptation remained absolutely correct for 20 years of clinical service, minimum marginal degradation. Of course, the patient is not a heavy boxer. This is one of the reasons why some restoration might age a little bit faster, but it's only to say that if you use the right protocol, we are able to do perfect, long-lasting restorations, even with a classical composite material and a classical layering technique. But next to the application of composite for a direct technique or indirect techniques or CAD/CAM or indirect ceramics, I also got interest to study the biomechanics, to understand the interactions between our adhesive techniques and the substrate, and especially to understand what is the impact of fatigue, of function and time over the behavior of our restorations. And you see here the machine which I fabricated in the early 90s. It was not the first machine, but based on the technology we had in those days. This is an electromagnet that is activating an artificial cusp. And you see the tooth, which is connected to an extra pulpal circuit to simulate the moisture and the pulpal pressure. And of course, we are loading those restorations and then evaluate with scanning electron microscopy the changes in marginal adaptation. So that is become my specialty, my research specialty, based on which I did my PhD and privatdozent dissertations. So actually, this is a little bit more modern technology. This is a new machine we are using for those tests. Just for you to visualize the function of those machines, we have also, with this specific machine, thermocycling. So the chambers are being filled up and with hot and cold water alternatively. And the teeth are being submitted to mechanical stress with slight eccentric movement. It's a quite sophisticated testing approach. And in fact, what we do before and after the mechanical loading, we analyze the margins, either enamel or dentin, and what we wish to see is what you have here, a perfect adaptation between the composite and the dentin here. But sometimes it doesn't work. And we have a debonding, we have a failure of the adhesive interface. And that is actually when the problem starts. Because if you look at the size of this gap, it's maybe 10 or 20 microns. It's a highway for bacteria. So it's the direct phenomenon that might lead to pulpal problems and recurrent decay. So it's something quite difficult to observe clinically. So here, with this type of test, we can isolate variables which might impact the behavior of the restorations before we use those products in the mouse. So this is the second aspect of my study on posterior restorations. So now I would like to share with you the philosophy that we developed in the perspective of clinical application, based first on our expertise or experience with clinical application, and also on knowledge into tooth and restoration biomechanics. First, that we need to make a clear distinction between small to medium cavities and medium-large above the CG, medium-large below the CG, and extensive cavities. When you have small to medium-sized cavities, you can use a direct technique with absolutely no problem. You see here the same protocol you have seen already briefly before. We use dentin to replace the dentin, enamel-like material to replace the enamel. And you see the final situation after changing those small amalgams. We are 5 years down the road. That was done with the Myris 1, which is a conventional microhybrid. And you see after 5 years that we have no visible change, no visible aging or degradation of the margins. I'm showing here 5 years. Why 5 years? Because 5 years is an absolute minimum to make any meaningful clinical observation. If you try a new product before 5 years, you will have no clue whether it works or it doesn't work. And that is part of a consensus which was published in the late 80s within the scientific community. In order to make a judgment on any new technique or material, we need to wait at least 5 years. You see here another case, 17 years after placement. And I take the opportunity to show you a little defect here. What is that? It is bonding. We used thick bonding layers in those days, but we should not have a thick bonding layer on enamel because this area will wear more rapidly than the restorative composite. Otherwise, the restoration is perfectly well bonded. There is no problem, but we had a slight margin degradation because of too much bonding applied on the enamel. When we have medium-large restoration above the CG, the biomechanical status is a little bit more critical because we must understand that more tissue is missing, more you need the restoration to strengthen the remaining tissue structure. So there is a correlation between the size of the cavity and the strengthening need. We have also part of the restoration which assume occlusion. So we understand that biomechanically, the role played by the restoration is different. You see here, 7 years after placement, I don't want to show you too many images now because I want to move to the clinical protocols as quickly as possible. But I want to illustrate the rationale behind the protocol that I will explain. You see here, it's medium large, but this is above the CG. And after 7 years, it behaves still relatively well. This is after 12 years. We had a little porosity here. We haven't corrected it. But otherwise, the morphology of the restorations have not changed. Margins are still looking good. Minor defects here, we can repolish it or leave it as it is. Never mind, doesn't change the behavior of those restorations. And here, 17 years later, we are getting close to 20 years. At this stage, I might definitely consider to do some repolishing of those little defects. But you see that even medium-large restorations, as long as you are above the CG, behavior is perfectly good. And we have some long-term data. I don't want to show you too many literature references, but here you see a randomized controlled study after 30 years made by a colleague from Sweden. And you see that over 30 years of function, we have only 1%, roughly 1% of annual failure rate, which is very, very small, actually. It's a very, very good performance. There is another more recent meta-analysis from Sigwart Heinze. They've got here over 10 years, but here it's a combination. It's the combined results of many different studies, actually 59 studies which were included in that meta-analysis. They have 90% of success at 10 years, which is the exact same result. It is 1% of annual failure rate, which is really very good. What about medium-large restorations below the CG? You have a slight worsening of the biomechanical status, which in turns increases, of course, the need for strengthening because preparations are deeper, likely medial and distal. We have also a significant part of the occlusion on the restoration. So we understand that Again, the biomechanics here might play a significant role. Those are, and I'll show you only one image here, or a few images here, 15 years follow-up of microhybrid restorations with cavities below the CG. You see more visible and severe degradation of the margins. Maybe also some functional component, functional risk factor, because you see a large wear facet here. It's nothing dramatic, but it doesn't look as good as the previous case. Same here for the large MOD. We made a liner here. You see some more visible degradation on the buccal wall, maybe where the cusp is a little bit thinner. We can argue about whether it would have been needed to cover the cusp or not. This you can always do later on. But here, the behavior is not as good as what we have seen with cavities, medium, even medium-large cavities placed above the CG. Now we have also some confirmation of these observations by the literature. We have here an 8-year result in a randomized controlled study, in a split mouse study, which is very, very good. And they had here really much inferior results compared to the previous situation. So it was significant changes over time for all criteria used to evaluate the restorations. Cracks, chipping, basically margin deterioration. And what I wanted to show you is that here, basically the majority of cavities, or half of the cavities, were below the CEG or having very, very thin enamel. So clearly this is having an impact on the restoration behavior. So this is one first question I wanted to answer, is that through what we understand today about biomechanics, is that direct bonding must be in principle limited to cavities above the CG, that's much better, medium, small, medium, medium, large, but not extensive cavities below with proximal extensions below the CG. Now, the second question I would like to answer is about the material. Which material, which technique, material and protocol is the best? Either conventional incremental, just layering, incremental with a liner. The liner is usually a flowable material with slightly lower E modulus, so it's something a little bit softer that works as a stress breaking layer. New technologies, bulk flow, where you fill up basically the whole volume of the cavity and you only keep a small layer for the surface, which we use for which we use a restorative composite, or just a bulk filling material. You fill up everything in one step. What is the best? Which information do we have for this? I would use only one reference, but the majority of clinical studies we have, which were included in this meta-analysis, independently provide the same conclusion. Up to now, and we have about now 5 years follow-up with the new bulk filling technologies, they have not seen any statistically different in the failure rate. So it is not maybe so totally true if you analyze the raw data. It's a little bit lower for conventional compared to bulk filling materials. But let's stick to the statistics. If we look at clinical studies by today with about 5 years of follow-up, in a meta-analysis, we don't have, I just wanted to confirm the number of articles which were used for this meta-analysis. It's 10 articles. And the follow-up was from 12 to 72 months, average observation period a little bit less than 3 years. So if you remember what I said before, we would like to get strong data from at least 5-year follow-up. So we don't have yet strong evidence that modern technologies, either bulk flow or bulk restorative, provide the same quality and longevity as classical composites used with a layering technique or a combination of layering technique and flowable base. So now let's look at what is my specialty. Simulation of function in a laboratory. And let's take as a reference conventional direct restorations. You might know those names. Tetric, it's a conventional microhybrid. This is a nanohybrid Tetric evoceram. This is another microhybrid. This was actually the adaptation we could obtain in dentin for medium-large restoration. 74, 64, 78% of perfect adaptation into dentin. Now with the same machine, exact same protocol, those are the results we obtained with bulk filling technology. This is Tetric, this classical restorative material, microhybrid, which we used as a bulk filling material. Extra low shrinkage, this is a Swiss company or a Swiss product, sorry. 2 versions with and without flowable. This is one of the first low shrinking technologies. SDR flow with a layer of ceramics on the top and sonic fill, which is another restorative bulk filling material. If you look at the adaptation into dentin, we can confirm that if you use a regular composite with a bulk filling approach, it's not going to work. The SDR flow or sonic fill, which are among the well-known bulk filling materials, they've got non-significant difference in terms of dentin adaptation, but you see that you're basically close to 50% of excellent adaptation into dentin after loading. With this exact same machine, exact same protocol, we could get to 74 to 75% with the classical layering approach. It's another publication from our university, because there are not so many universities using those machines and those protocols. Here my colleague Exxon de Campos, he tried other materials, bulk fill, the Venus bulk fill, the Tetric evoceram bulk fill, Surefill SDR, flowable bulk fill, sonic fill, which is another type of bulk fill material, and the control group, the ceramics, which is a classical Ormoser for use, sort of universal composite system. If we go to surgical dentin, and you need to look, by the way, at the orange bars. I think you realize that. So this is the post-loading condition. You see that none of the products but sonic fill provided adaptation above 50%. Only sonic fill provided adaptation above 50%. We're in the range of 60%, 63%, if I remember well the exact data, which is not the worst result we ever had with bulk filling material, but we are still relatively far from the 74, 78% of classical layering with conventional composite material. I personally trust those studies to give us a more precise idea by today of the difference between new technologies and classical technologies. And I would say also we should perhaps layer bulk filling materials and not to use them even in medium large, even in medium cavities as a bulk filling approach. That's maybe a small mistake, conceptual mistake. We are evaluating this hypothesis with new studies right now. We don't have all the results, but we hope to see much better results if instead of bulk filling, you might use 2 or 3 layers. with these new technologies. Otherwise, to conclude on the choice of the material and the technique, this is the literature review on in vitro testing, and we have also made a selection of what is really good in vitro testing for posterior restorations. We found that overall the best technique to be used for large cavities below the CG is indirect. So I'm just coming back to my suggestion during the first part of this presentation. Best is to use an indirect technique when you have a large and deep cavity. If you target high quality, long-term results, that's definitely the preferred option by today. Okay, so now we are ready to enter the third part of the presentation, which is about the clinical protocol for which decay, extent, and geometry. Because I would like to make a small distinction between small to medium and medium to large, so that you can appreciate which protocol I personally use. For the reasons I mentioned before, the bulk filling technology is not part of my standard of care protocol by today, but I will show you how and when I use bulk filling technology during this part of my presentation. But the basic protocol that I still have today in 2020 is to use a classical composite, such as a classical microhybrid or modern nanohybrids. Small volume. Now, when it comes for the occlusal part of the cavity, small volume, normally I bilaminate, dentin enamel. If I have a little bit larger volume, I might use an oblique approach or vertical approach. So it means two different oblique increments for the dentin, always one single step for the enamel. And if I even a little bit larger, I might use first a liner, flowable composite, then I might go with oblique layering, and finally enamel for the occlusal. And this, of course, relates to the volume of the restoration. What about the proximal? If you have a small proximal cavity above the CG, I might go with the single increment. Roberto Spriafico, my composite brother, has been one of the first to show that when you have really a small proximal cavity, it works perfectly well if you go with a single increment. If I have a little bit wider facial to lingual extension, but still above the CG, a good solution will be to layer horizontal. You might layer vertical also if you like. And when we have not only a wider proximal cavity, wider from facial to lingual, but also deeper at the CG or below the CG, I personally still like to use the three-side technique. First layer horizontal and then two layers vertical. There are variations of these basic techniques. I'm not saying that those are the only techniques. You might have heard about oblique technique also for the proximal, combination of flowable and restorative material. All those different techniques support the same concept of handling polarization stresses in a better way. So let me show you now step by step how we proceed. First, for a small size class 1 and 2 cavity. What is small size? It means from a buccolingual dimension, the cavity is less than 1/3 of the buccolingual dimension. And when we open the cavity, you see that really the volume of the restoration is relatively small. And in the proximal, what is also for me the condition for a successful application of those techniques is to get plenty of enamel. We have nice, thick proximal enamel. We could make a nice bevel on the cervical, which is also needed to get a perfect adaptation in this area. For proximal class 2 cavities, I like still the classical sectional matrices like the Garrison, for instance. Why? Because those matrices, they give you a good visual access. While modern matrices, which have a double curvature, not only from lingual to facial, but they have an increased curvature from cervical to occlusal, and especially on the occlusal, the curvature doesn't give you a very good visual access to this area. So I still prefer to use those matrices. The ring could be the classical metal ring. We have some sort of 3D rings that works also very nice. You have a space so that you can come on top of the wedge. That is another type of ring that I like very much. It is the Paludent ring from Dentsply previously, that was from Triadent, a New Zealand company. This is very good. It is very stiff. It is very stable. Even though I like to work with different rings, I could not find one single ring that works for all the situations. Depending on the position of teeth, sometimes if you have a slight rotation of one of the teeth, it's useful to use another ring. Depends also on the opening of the proximal cavity. If you have a wider cavity, those rings do not work because they will enter inside the cavity. So then you need to use either the 3D Garrison or the Paludent. So it's always good to have different systems at hand so that you can fit every clinical situation. Important to say that the wedge is not used to separate the teeth. The wedge is used to basically keep the matrix in close contact with the margins in the cervical. In regard to the build-up, here I build it up in 2 layers, the proximal wall. This was here the first layer. You see the first layer on the cervical. It's about half of the cavity, and here it is the second half of the proximal wall. Very important, dear colleagues, it is a key point. Keep control of the height of your marginal ridge. Make sure you don't go too far high, because otherwise you will have a problem to control the anatomy of the teeth, of the restorations. You see here, the matrix is coming just above the contact, so that it's very easy to control the level of your marginal ridge. Okay? Now, for dentin, in such a cavity, no need to layer. Even if you use a conventional material, you don't need to layer. You use one dentin increment, that's it. Shave the dentin increment so that you create the space which you need for placing the enamel. Again, we use dentin to replace dentin and enamel to replace enamel. I'll be very honest, I hate monochromatic restorations. It's not good enough for me. I know it's on the path of your teeth, but I have a vision of something which is better than a monochromatic restoration. That's why I don't like so much CAD/CAM for high quality dentistry. Especially composites tend to be really monochromatic. If I can do it direct, I prefer to do it direct, to be honest. Now this is the sculpting. Look at that image. We sculpt the enamel. Now we are at the very last layer. This is the enamel. We sculpt the composite in order to emulate normal tooth anatomy. It doesn't need to be deeper, but you also don't want to make your anatomy flatter. Because if it is flatter, this is the problem you will face. The red line, which is a flat anatomy, is good, but it's too high. So you will get interference, occlusal interference. You will lose time to correct. That will create stress on the margins. While if you follow the normal cusp profile, then you will get a much better anatomy and occlusion and function. The key points, the red spots, are marginal ridges. Again, you need to make sure that your proximal anatomy is done right by placing the matrix with the right height, and also the occlusal contact. So you need to respect the normal cast profile. And that's why we have developed those special sculpting instruments like the DD1, DD2. That's from the set I've developed for you freely. Very simple set of instruments, but works really very well for posterior restorations and anterior restorations. With these 5 instruments, you don't need anything else. You can do everything. So you use that one and the other side to sculpt your occlusal anatomy. So now this is the situation just before applying the surface colorant. You might like this or not. I appreciate that sometimes patients don't like this brown shade, but I personally love to do it. I first place a very small amount of Fisher effect shade. There are also restorations made with the same material I presented last week, the Inspiral. I place a teeny bit of effect shade, Fisher effect, into the grooves. I clean it with a brush and micro brush. The brush is needed to go inside the grooves so that you can take the excess of color. Then you brush away with the micro brush, you take away the excess of color. And we finished with a little more eyes effect shade to make it look even more natural. It's an artistic step, if you like, that gives really a lot of fun. So you see the occlusal perspective, you see the facial perspective. So it gives you a sort of 3-dimensional view of what we do. Now pay attention to the anatomy. It is the anatomy before removing the rubber dam. Now this is the anatomy on the pictures taken a few weeks later. As you can witness here, there is no change in the anatomy. Same. But that relates to our ability to follow the right protocol. Use the remaining tooth anatomy to sculpt your composite in a proper way. Use a good sculpting instrument to make this step. And sculpting is not only a matter of saving time and reducing stress on the margins, but also it creates a stress breaking, or it has a stress breaking effect. When you go with your instrument deep in the occlusal anatomy, nearly in contact with the underlying dentin, when you light cure the restoration, this will separate, this will break the stress buildup between the facial and the lingual walls. It's a very effective concept to reduce stresses along the occlusal margins. So you get an improved polarization pattern, which allows you to do the entire occlusal anatomy in one step, which is not possible otherwise. If you don't use this technique, you need to build up the occlusal in multiple small steps or multiple small increments, which is a big waste of time. So now let's look at the protocol for medium-sized class 1 and 2, and then I will finish with large, medium-large. Here we have defective amalgams, which have to be replaced. We have also a mechanical component. You see here a wear facet, so that's something to take into consideration. So this is after having done the preparations. We still have enamel everywhere, here, here, and here. You see that it's not anymore a small cavity. It's medium, medium, large, medium here, medium, medium, large. We are having an opening, an occlusal opening, which is much more than 1/3 of the buccolingual width. My preference, I don't have the time to go in details, but I want to mention this at least, that my preference today is to go with the classical 3-step total edge or edge and rinse. In fact, the key for long-term stability of adhesion, dear colleagues, is to get a separate bonding step. You want to create a fully hydrophobic or mostly hydrophobic hybrid layer, which is impossible with any adhesive that will combine primer and bonding. Modern adhesives like universal adhesives are not bad products, but because they have in common the fact that, or this concept that they mix together primer and bonding, like the first generation of one bottle system, one-step self-etch systems, they are likely to be less stable than classical adhesives. So my preference is three-step total etch, or as an alternative, which I like very much also, two-step self-etch, but always separate priming and bonding. I think this is really one of the key. What we understand today about stability, long-term stability of adhesion relates to the use of a mostly hydrophobic adhesive interface. When I have a larger volume, I mentioned the fact that we want to create a stress breaking layer. That has been strongly evidence-based into in vivo and in vitro literature, especially in vitro, where it is easier to show that this step might make a difference compared to a technique without the flow. It's very difficult to evidentiate the impact of that step, for instance, into a clinical study. So we use a thin layer. Now, you look here. This is the cavity without the liner. This is the cavity with the liner. It's about 1 millimeter, 1.5 millimeter maximum. Understand that if you create too much flexibility by adding a lot of flow, you get a counterproductive effect. You obtain a counterproductive effect. You get too much deformation, and in turn, it will even create a less favorable situation. So again, all this has been studied in the literature. So we just need to stick to what we know. So liner for large cavities, but around 1 millimeter. It's a stress breaking layer. It's not to fill up the cavity. What you have seen already before, for class 2, we like to first close the proximal box, transform the class 2 into a class 1, and then finish the restoration as a class 1. Here we have, in fact, 2 vertical layers. I hope you can see here the cavity is open. So the first increment is closing the cavity, but we leave an open space here. Why? Because we don't want to get too much tension between this wall and this wall. So it's another concept to reduce the stress buildup where we have large buccolingual cavities. This is a relatively large cavity. So now we are closing. So that was when I was building up the first layer, vertical layer, then I'm closing with the second vertical layer. Okay? I did the exact same. So now if I just return to this image, this is first layer. Now you have first and second and completed cavity here, or completed proximal buildup. You then repeat the same operation for mesial and distal. Here, I think we can go 1 step. Here, we went 3 steps. 1 gingival and 2 vertical. Of course, you cannot differentiate here. I just outline here 1 cervical and here it's separation in between the 2 verticals. Why? Because here it's even a little bit, it's not larger, but it's a little bit deeper. So I summarize. We close the proximal. We transform the class 2 into a class 1. This is our liner. As you have seen also, there are a lot of small details. I'm sorry, but this is important too. I built up proximal walls 1 by 1. Some people do it together. It's really up to you. I personally found it a little bit safer when I do it step by step. Then I go again with the dentine. Those cavities are not extremely large. So the first one, I go in 1 step. The second one, I go in 2 steps. So I separated here. I'm sorry that I don't show you more images, but as I have more cases to show, I want to explain the concept. So here you have a facial increment. Here you have a lingual increment. and then one single increment for the surface. We use the remaining tooth anatomy to create the desired shape and anatomy. Those teeth are a little bit flat because the patient has some parafunction, so we try to be careful here that we don't have too much material. You see here the small instrument from the composcope, U3D composcope set, that is really very nice and very sharp to create these fine grooves. And then for those who like, the last step, here we used the Fisher effect and the ice effect of the Inspiro system to characterize the surface. This is, of course, absolutely optional. If you prefer not to use the surface colorant, it's absolutely fine, of course. And this is the final view from a lateral perspective. You see what I said, it's relatively flat. We knew that we had little space, so we had to respect the original anatomy and function for this specific patient. But of course, compared to the previous situation, it is much, much better. So I mentioned that I choose different materials because sometimes I see an interest and an advantage of new technologies. And in general, I'm not necessarily jumping into every new technology with no good reason. It's the same with digital technologies. As I said last year, it must be better and faster and more effective, which means cheaper. I would like at least 2 out of those 3 conditions to be met. If it's only cheaper, it's maybe not enough. If it's only faster, it's maybe not enough. If it's better, that might be, of course, very positive, but if it costs 10 times the price, it's maybe not rational anyway. And that's the exact same with composite technologies. I see advantages of bulk filling materials, maybe not as a true bulk filling, but I also see an advantage if I have a deep cavity with no enamel. Occasionally, here the patient was traveling from the UK. The patient was only 1 day with me. I didn't plan to do any indirect restoration, so I need to find a solution to accommodate the fact that I have a little bit deeper cavity. So why not using, I like to use flow when the cavities are really deep, where it is a little bit difficult to keep the matrix in contact. You don't want to condense a heavy, highly filled material. I think the flow here has very good consistency. So I was using the SDR flow, a bulk filling material. That's basically the most well-known material in this category. But I don't use it truly as a bulk. I use it as a flow, and on top of it, I will restore my restoration with the same technique that I have demonstrated before. So that's the dentin build-up. It was 2 layers, 1 buccal, 1 lingual. This is the shaping, modeling of the enamel. This is done in 1 step. Just to come back and make sure, because I went a little bit fast, I use here the SDR flow not to do the whole proximal build-up, but I used it only to do a liner. So I did maybe the first 1.5 millimeter with this material that has a very low shrinkage. So it will be probably a little bit better than a classical flowable material. And this is the final restoration after sculpting the anatomy. And this is the final result. Here, I had to accept a small compromise because I couldn't organize myself to go with an indirect restoration, and it was not planned by the patient to come back. So then I made a selection, a specific selection of material, which is a little bit different from my traditional approach, trying to take good advantage of specific properties of new technologies. There is a last key element in regards to class 1 and 2 restorations, which is the rebonding with a hydrophobic resin. That's something that I didn't do for maybe the first 5 years. And in the early 90s, I started to use that technique, and I've seen a huge difference. There is no research really supporting this. It's really by clinical application. By doing thousands of those restorations, I can really confirm that it's making a big difference. What is the rationale of rebonding? Rebonding means that we want to seal the minor surface and margin defects, which always exist. Even if we don't see them, after finishing, they're always, and just doing the restoration, there are always micro defects at the margins. And also as a temporary surface glazing, because it's very difficult to sculpt deep the anatomy and then to polish it in a perfect way, because we don't have instruments to polish this. We should use pastes, but it's so much easier to glaze the surface for these posterior restorations. And also to seal the very, very thin, deepest part of those grooves. Because something that I have observed also in the past, that when you sculpt those very deep grooves, pigments and food might be stuck into these very deep occlusal fissures and grooves. So the rebonding will solve all those problems. So the timing now, initially we were doing the rebonding just after finishing the placement or the sculpting. And we found that the best moment is to proceed with the finishing, but before the polishing. If you use silicone instruments, then you will create a smear containing silicone, and then nothing is sticking anymore, neither to the tooth nor to the restoration. So you must do it after finishing using fine diamonds or discs, but not after using silicone instruments. The technique is very simple. You have two options. Either you use phosphoric acid, your normal etchant, enamel etchant, or what I found also more now around 15 years ago, that it works very well with a two-step self-etch adhesive like the Adhesive, the Cure Clear Fill Adhesive. So I use a self-etch primer as a cleansing agent to clean the smear and everything that might prevent the bonding, the hydrophobic bonding or the hydrophobic sealer to penetrate the defects. And then I use the Adhesive bonding or Iliobond, which is another well-known hydrophobic adhesive from Ivoclar, or any other hydrophobic sealer. There are many, many products on the market for sealing of composite restorations. But what is important? Hydrophobic bonding or hydrophobic product for the sealing. That's also the kind of product we use sometimes for sealing temporaries. So the rationale of the rebonding is to make the margins perfect, because those micro defects, they are of course exaggerated here. On my drawings, they are never as big as that. But if you go under the scanning electron microscope, you will see those little cracks, those little defects. Those defects could be just at the margin, could be sometimes also inside the enamel. You might have micro cracks into the enamel. So what we do with the rebonding, we seal those margins, and then we cover everything with the glycerin, and we light cure. So that will basically remove the inhibited, oxygen inhibited layer and provide a perfectly nice and smooth surface. It seems to be a detail, but believe me, that makes really a difference. And also it helps to expedite the finishing step. You really don't need really to do any true polishing. Maybe you can just go with a silicone polisher over the enamel margins if you feel it is needed. So I think that completed pretty much this very, very quick overview. But I think within the time frame of this webinar, I trust I've been able to cover some of the most important topics related to direct posterior restorations. Please don't run away. Stay in front of your computer. Leave Altixident technical team to collect the questions. I'm staying with you. We'll reply your questions, but just give us a few minutes to collect the questions, and then I will answer your questions. I thank you already for your kind attention, but it's not finished. Stay with us. We continue in a few minutes. Okay, so I think now we are ready to start with the questions, and we will start with a question from Elena. Good evening, Elena. Bonsoir. As we did last week, I will repeat the question for everyone so that you can know which the question was. So the question of Elena is, do you complete rehabilitation of attrition or abrasion using the direct method? We have somehow covered this question last week, but to make a long story short, the direct method, yes, is an option. We normally reserve the direct option for moderate to severe cases. This is what we call interceptive, which means we don't use the direct method for very severe to severe cases when we have a huge loss of tooth structure. Something very important maybe to mention is that we might use a combination of direct and indirect techniques. So knowing that the level of tooth wear is rarely uniform across both arches, we might treat some teeth with a direct technique, some others with an indirect, or let's say a CAD-CAM. We might also use combinations of ceramics and composite. And I think this is really a breakthrough into the treatment of tooth wear, which is to avoid what I call a monotherapy. Monotherapy means we use the same technique for every case, and we use the same material and the same technique for every tooth. I think this is definitely not the proper approach, but okay, I cannot, let's say, go in so much depth to explain this, but remember, after summertime, we'll have 3 webinars specifically dedicated to tooth wear treatment. So I would just suggest you, if you have interest for this domain, to be with you in September. Okay, thank you, Elena. Now we reply a question from Daya. Good evening, Daya. Her question is, can direct frontal restorations be carried out only after restoring the function on the lateral teeth or on the posterior teeth? I think here we don't have any strong scientific occlusal or functional rationale in regard to starting first with the front teeth, then continuing with the posterior teeth, or to do the other way around. I see more a practical, a technical rationale, especially if you use a direct technique. If you use a direct technique, it will definitely be easier to start with the posterior teeth and then to adapt the anatomy of the front teeth to the new vertical dimension of occlusion. If you go the other way around, you first build up the front teeth, it will be a lot more difficult to adjust the height of all your posterior teeth. So again, it's a pure practical matter or practical reason to start with the posterior occlusion and then to move to the front teeth. If you use CAD-CAM or indirect, I would say that in principle, it is open to your preference, but I would say with my own approach, I always start with the posterior and then I move to the anterior. There are some other concepts like deprogramming which I personally don't really believe brings a lot. At the end, you don't deprogram parafunctions by changing the occlusion for a certain period of times. This we know doesn't exist. So let's try to stick to what is the easiest from a clinical standpoint. But I would not fight. I don't say it is wrong per se, but I think the scientific rationale is not very strong in going first with the front and then with the posterior occlusion. Okay, so thank you for your question, Daya. Now we take the question of Anastasia. Good evening, Anastasia. How do we avoid chipping of the restorations? That's a very good, important, very good and important question. I think we needed to answer this under the light of the two indications we have been talking about, just normal anterior restorations and anterior restorations in the context of tooth wear. At the end of the day, we need to find a good compromise between the space, the restorative space, and the function. Let me be maybe a little bit more clear on that. If you have a patient with no parafunctions, you can afford to have a smaller or thinner restorative space. For instance, if you do some aesthetic build-up in the front area in a patient who has absolutely no parafunctions, you might allow yourself to be a little bit thinner on the edges, or when you join with your composite restoration, you join the natural tooth structure. Conversely, if you treat the heavy bruxer and you want to restore the incisal edges of this bruxer, you need to give yourself more space. And I would say the minimum will be 1.5 millimeter. So it's really very much a matter of the functional environment. So there is no fixed minimum dimension for restoring anterior restorations to avoid the chipping. So it goes from nearly 0 in non-parafunctional cases up to maybe 1.5, even sometimes 2 millimeters in heavy bruxers to avoid the chipping. The question I think was answered. Thank you, Anastasia. Let's take now the question of Alice. What do you think, good evening, Alice, what do you think about Japanese photopolymeric materials clear field? Well, Japanese have, in general, very good chemistry. So I think either Curare or Curare material, Tokuyama materials, GC materials have very good technologies. Sometimes the shading concepts are developed in the perspective of Asian teeth, and that could be a problem in terms of the shading system and the colors of the material. For instance, if we take an example, not the clear field one, because the clear field one I know by name, I know what it is, but I personally have no experience myself. But if you take, for instance, the Tokuyama Asteria, you would have problems in Caucasian teeth. Many colors are not or useless for Caucasian teeth. So that's one limit. I think in regard to the clear film material, it's not a super sophisticated aesthetic material. I've given the list, in fact, of materials which are really top level aesthetic materials and which are fitting with the natural layering concept. There are other systems with other shading concepts. Don't take me wrong, it's not that I want to be negative about those composite systems, but I'm very, very much convinced that we need to stick to something very simple and reliable. Think not only about the shading system, but think also about the shade recording, that you have a reliable shade recording system that, for instance, do not exist with any of the Japanese products. You either need to fabricate a lot of samples by yourself because you don't have a prefabricated shade tabs or shade guide. So it really depends. If you're happy with it, if you have very good results, don't change. If you find in certain occasions difficulties in getting the right color, then you might need to look for another product. Okay, so thank you very much, Alice, for your answer. I hope I have not been responding to your question in an excessively negative way. What I said during my presentation last week, and the message I was trying to convey, and trying to be a little bit away from any commercial perspective, is that we need to give priority to simplicity and reliability. And honestly, there are very, very, very few systems on the market which provide both simplicity and reliability and a very high aesthetics. So there is no secret. Composite is not just composite. There are some materials which are definitely better and easier than some others. With a lot of experience and skills, you can still manage to do fantastic restorations, not with every system, but with some other systems. But this is my profound conviction that we need to stick to simplicity and reliability. Okay, so now let's go to the question from Yasko. Question of Yasko, good evening, Yasko, is about direct and indirect pulp capping. That's a good point. Indirect pulp capping, it's not part of modern dentistry anymore. It's a concept that has vanished away probably already 20 years ago. So indirect pulp capping is something you can simply forget about it. What is important is to get a good adhesion. With a good adhesion, you prevent bacteria to get in contact with the pulp. That's all what we need to do. Direct pulp capping is slightly different. And for sake of simplicity, I will try to only consider two situations for the direct pulp capping. In consideration of a vital tooth, of course, and a non-symptomatic tooth. Otherwise, we are not in the field of direct pulp capping. But let's say if you have a non-symptomatic pulp, or let's say you have a higher risk of complication. But let's assume we treat a tooth non-symptomatic and vital. If we have a small pulpal exposure which doesn't bleed, you can etch the pulp, you can prime the pulp and bond the pulp, and the pulp will be very happy. That has been demonstrated in several histological studies. If you establish good adhesion over the pulp and then you seal the cavity, you will not have any big problem. But if, on the contrary, the pulp is bleeding, there is no way you can establish adhesion. Then you need a cement, you need a pure or Mura pulp capping material, either a classical one like calcium hydroxide, some modified materials with calcium hydroxide and resin, some modern materials, biodentin, or some new cements, which work very well for that. When you have sealed and the pulpal opening, you have stopped the bleeding, then you can proceed ahead with your adhesive procedures. But something very important, if you have a pulpal opening and situation for direct pulp capping, you might be in the situation of a deep cavity. It's more likely to be the case. Then you need to be careful. Now, if we come back to what we were discussing a little bit before, posterior restorations, try to avoid using a direct technique when you are below the CG, because otherwise you can't grant a perfect seal of your restoration. And then if you do a direct pulp capping, whatever the technique, you get exposed to a more higher biological risk. So more than the technique of direct pulp capping, or apart from this, it is very important to be able to seal the cavity in a perfect way. Anything big below the CG, you must go indirect. Okay. So, Daria, good evening. So, the question of Daria is, why do I need a 1 to 1.5 millimeter? Oh, but actually, I don't know if we have, well, maybe it's the same Daria, I assume. Yes, 1 to 1.5 millimeter of fluid composite, and what other hydrophobic sealers can be used for the final sealing of restoration? Thanks. So the role of, now we are definitely into the field of posterior restorations. In fact, you need to understand this layer of 1 to 1.5 millimeter of fluid composite playing multiple roles. A first role, which is a very simple one, is to basically wet the cavity floor in a very efficient way so that you don't have any gap between your adhesive interface and the restoration. So it's a pure practical function. There is a second function, which is called stress breaking function. The two structure will be submitted to some stresses during the contraction of the restoration. When you place the composite, with the shrinkage of the composite, whether it is a normal composite or a bulk filling material, it's still shrinking. So you will get some tension. And this layer of flow, which has a lower E modulus, which is a little bit softer, it's not like rubber, of course, but it's a little bit more elastic, will deform to absorb those stresses. And the same function happens during function. It avoids to overload the adhesive interface. But there is an optimal thickness. If you apply the same concept, but instead of 1 to 1.5, you put a lot more flowable, soft material, then you get to a counterproductive effect because you increase too much the deformation. And in turn, this might generate stresses which you don't want to have. So that has been researched. There's been a lot of research on what is the ideal thickness of this layer and what is the optimal stiffness, or we calculate the stiffness in the form of the E modulus. So again, what I said is the result of quite a number of research papers and publications in vitro, in vivo, that brought us to this conclusion. Okay, so thank you, Daya, for hydrophobic sealers. You can use, for instance, a rather hydrophobic bonding resin, like the one that I mentioned, which is the Clearfield Purell Clearfield AC bond. You can use very classical hydrophobic bonding, like from the Ilio bond from Ivoclar. There are some materials like Discover from Ultradent. You have materials from GC, Optiglaze. You have from Errors. The material is called Palaseal. There are a couple of other products, of course, many other products even on the market, but I don't know them all because I don't use them all. So just a few brand names. It needs to be hydrophobic. It needs to be a specific surface sealer for this indication. Okay. So now, question from Elisabetta. Good evening, Elisabetta. Your question is, thank you very much for the information. I have a question about anatomy. How do you make such beautiful bumps and fissures and at the same time get into the bite? Okay. It often happens after the restoration that I have to correct the bite in large, but in a significant way, and subsequently I end up with wrong anatomy. My dear, that's the problem I had for quite some time before I basically managed to find a good solution. Let's say, if we speak about class 1 and 2 restorations, there are a few reference points that I didn't have the time to mention in detail. In fact, you need first to check the occlusion before you start with the preparation. While you wait normally 1 or 2 minutes until the effect of the anesthesia is getting efficient, look at the anatomy of the teeth before the treatment. Try maybe with an articulating paper to mark the contacts. Watch for the wear facets. Look at the marginal ridges. If you have a contact of the antagonist cusp, try to capture mentally the critical areas where you have the antagonist cusp coming into the surface, and try to create a sort of 3D model of what the optimal anatomy could be. And then use what remains from the anatomy. If you have the cusp, sculpt along the cusp profile. Same on the other side, so that you will create an occlusal restoration that follows the normal inclination of cusps. It will be more difficult if you have to build up the entire anatomy. So that's why for tooth wear treatments, we use very often molds, silicone molds, that will give you the exact anatomy which you need. But if you don't go for extreme build-up with composite, the key point is using your anatomical references as what you have created before you start with the preparation, and try to use any remnant of the anatomy to create the right inclination of cusp. And normally that should work progressively better and better and better. Okay, but don't give up. Don't give up. Keep on trying, and you will see that you will improve your results steadily, one case after the other. But thank you very much for your question. We have now a question from Chris. Good evening, Chris. Chris's question is, in deep cavities with close pulp proximity, do you prefer using flow composite or resin modified glass ionomers? Also, can you please share your protocol and preferred materials for deep margin elevation? Okay. So the flow is my preferred material. When I have a deep cavity, let's say whether I'm close or not so close to the pulp, because that depends mainly on the age of the patient. If you have a young tooth, you will, even a medium-sized cavity, you are close to the pulp. If it is an older tooth, the pulp might be anywhere a little bit further, but you might still have a deep cavity. So for me, the flow, for the reasons I have explained before, is a key element of success. Resin-modified glass ionomers, it's a little bit like indirect pulp capping. We need to understand it, and don't take me wrong here, the generation of glass ionomers or resin-modified glass ionomers being used as a base material is something from the past. It's something that definitely doesn't belong to modern dentistry anymore. It's also something that the research has been showing also, and if you look at the right research, the research has been showing that those materials first have poor adhesive properties. They release fluoride, but in a much in a quantity which is far too low to have any effective effect. So either classical glass ionomers or resin-modified glass ionomers are of no use in terms of fluoride release. That was a myth. That's really a myth. We know it makes nothing. So resin-modified glass ionomers, in short, is the worst of the two materials. It doesn't have the good properties of classical glass ionomers, and it doesn't have the good properties of composite. That served a certain purpose during a transition phase, especially before we had really effective denting bonding agents. But at the moment we have effective denting bonding agents, you have absolutely no reason to use a resin-modified glass ionomers. So this is a sell to your colleagues who didn't watch the webinar. And some materials even have extremely negative properties, but I don't want to enter this discussion really in depth. I have only one indication for me in regards to conventional glass ionomers. If you are in a compromised situation with very, very deep cavity margins, before you might eventually go for a more ideal treatment, a classical glass ionomer as a base material, and maybe even to relocate the margins, might be a suitable situation, but not necessarily resin-modified glass ionomers. Many of them do expand. They have very poor adhesive, self-adhesive properties. So if you need to do anyway adhesion with a conventional adhesive system, you have no reason to use a resin-modified glass ionomer. Now, in regard to the deep margin elevation, we have now basically we have about 25 years of experience. When we first published this technique, it was Roberto Spreatico, who is my composite brother. We published the technique in 1998 with the immediate dentin sealing. That's also during or in this publication that we have created this terminology, immediate dentin sealing. But the cervical margin relocation, which is the original terminology for this technique, we described it at the beginning with flow. If you wish, you can also use a normal restorative composite, but the reason why we did like the flow is also for practical reasons. When you have a deep margin, you might not be able to place a wedge, or you should normally not be able to place a wedge. So if you go and compact a relatively stiff restorative material, there is a risk you can move away the matrix from the tooth, and we don't like to do this. So the flow has the advantage that as soon as the matrix is fitting the cavity, then you can go with the flow and you don't displace anything. Again, there is a limitation. If you respect the indication for cervical margin relocation, 1.5, maximum 2 millimeters of composite should work. If you use flow, however, you need to use a highly filled flowable material. And highly filled means above 65% of filler per weight. Because if you go with the flow that has a lower filler content or has really a low E modulus, you might run into problems again because of too much deformation. But if you use normally a highly filled flowable composite, it will work, and be careful that you don't exceed 2 millimeters of flowable material, and that will work very, very well. You know what? In 25 years, we have been using this technique. And I don't lie here. It's really, and we have done hundreds and hundreds of those cases. I have never seen one recurrent decay below a cervical margin relocation done properly on the rubber dam. Same for Roberto. We discussed that with Roberto very recently again, and he said, I have never seen one failure case in 25 years. So I think it's a very, very safe technique. So, thank you, Chris. Good evening, Bianca. How can I prevent? So the question of Bianca is, how can we prevent the metallic matrix from bending? And how can we avoid bubbles in doing horizontal layering in class 2 restorations? I'm not so sure to understand bending. If you probably refer to sectional matrices. Some, I think, this is your question, some sectional matrices are made of a very soft metal. And you need to handle them very, very finely, because otherwise they deform, they bend, they do like folds, and that is very disturbing. By reformulating your question, I think that I have given basically the answer. You need to be careful. Just, you need to handle them very, very finely. Having said that, some matrices are a little bit stronger. If you take, for instance, Garrison matrices or Paladin matrices, they are not so, the metal quality is relatively good. I've got recently, but to be honest, I don't know the brand, because I received also sometimes materials to test. Some materials, some matrices, they're very thin, but the metal is so fragile that just by looking at them, it starts already to bend. So if you really have this problem, try to look for Garrison material, try to look for Paladin. Paladin is the dense ply system. I trust you should be happy with those systems. So thank you for your question. And the bubbles, oh, sorry, I forgot the second part. The bubbles, it probably depends on the consistency of your material. You need to get a relatively firm material. If it is the flow, it's a matter to inject the product slowly enough so that you don't produce bubbles, and hopefully the bubbles are not inside the material. What might be probably more problematic is with the restorative material. Then you need to apply it in relatively small quantities. Have your instruments perfectly clean, because if the instrument is a little bit dirty, having a little bit of composite or resin attached to it, when you go into the cavity, it's sticking to the composite, and you sort of displace the composite, and it creates defects, bubbles or gaps in between the layers. Two tricks. One is to heat up the composite so that it tends to flow and apply in a better way into the cavity. That's very useful for posterior restorations. And also, instead of using a metal instrument, if you don't have a very smooth, perfect one, like a plugger, you can also take a microbrush, very, very slightly moist from your bonding, and you use the microbrush. And the microbrush is a very, very good instrument to spread the material at the bottom of the cavity without getting defects. So I hope these tricks will help you. Okay. So thank you, Bianca. Now we move to a question from Victoria. Good evening, Victoria. Her question is, tell me, please, what can be associated with sensitivity after restoration when biting on the tooth? Is it not possible to chew solid food? The situation occurred during the restoration of various defects in death. Thanks. Victoria, after the lecture of tonight, that should not happen anymore. In fact, what is dentin hypersensitivity on the pressure after doing a posterior restoration? It is a gap below the occlusal floor. And that happens normally more in young teeth, because young teeth have a highly tubular dentin. If you do anything on sclerotic dentin with no open tubules, that will never happen. So I guess it's whenever you work on tubular dentin. So now, how can we avoid gap to form between the dentin floor, especially the occlusal floor, and the restoration? There are a couple of secrets, but not so many. The first one is the adhesive system you use. you need to use the best adhesive system or some of the best adhesive systems we have on the market. And again, I don't want to do any counter advertising. If you look for the best here, there are basically two systems that I will recommend. Total Edge 3-step, but you need to be careful not to over edge dentin and not to over dry dentin. But if you understand that, if you use a 3-step etch and rinse adhesive system like Optibond FL, for instance, you will have amazing results in terms of the quality of adhesion. Having said that, total edge systems are known to create a little bit more post-op sensitivity. So if you want to play safe, really to be safe, maybe you switch to the other best adhesive technology, which is the 2-step self-etch, like typical golden standard adhesive system. Clearfield, Curarec Clearfield as Ebon. You have a self-etch primer that will prevent normally over-etching of dentin or drying of the dentin. But be careful that your etchant is a good etchant. That when you apply the etchant along the enamel margins, the etchant doesn't get all the way to the occlusal floor, because in this case, if you double etch your dentin, then you're dead. Bad adhesion, if it is medium, deep cavity, compromised adhesion, permeation stresses of the composite, perfect recipe for post-op sensitivity. So quality, basically mastering the application of the adhesive. Second point, stress. Permeation stresses from the application of the composite. So you need to be very careful with the layering technique which you use. If it's very deep cavity, maybe if you use, for instance, bulk filling technology, go in 2, possibly 3 increments. Don't follow the full bulk technique, because that will still generate too much stresses. If you use a classical technique, you need to go in smaller steps, as I demonstrated basically in those clinical cases tonight. And if it's really very deep, there is no secret, indirect. I would say that if you understand those principles and you apply those principles in a proper way, to make you optimistic about, let's say, the way you can handle this problem. If I would not be asked the question of post-operative sensitivity during the programs, I would not be even able to spell it correctly. Post-op sensitivity in my practice has disappeared. I would not even say 0.001%. It's absolute zero, absolute zero. I don't know what it is to create post-operative sensitivity on any of my cases. I can mention millions of other problems that I had, like you, but not this one. This one has been totally eliminated with, let's say, the advent of the 3-step etch and rinse adhesive generation. That is so effective. If you control your layering technique, you are done with the post-op sensitivity. Finished. Good. I'm sorry if I took a little more time on this question, because it's a very, very important one. Okay. So I really hope it will help you, Victoria. Now, good evening, Stanislav. Thank you to be with us tonight. So Stanislav's question is the following. Tell us about your experience of treatment of cervical cavities in class 5. What is the treatment protocol? Is an interdisciplinary approach used in such situation? Okay, I would maybe make a distinction in between carious cervical lesion and non-carious cervical lesions. So I will start with non-carious cervical lesions known about as abrasion, abfraction, or erosion. Actually, could be the three phenomenon separate or together. For non-carious cervical lesions, if we don't wait for too long, you normally need a relatively thin layer of composite. And in those cases, I use mainly flowable composite, unless it's a very big volume. I like to use, for those cervical lesions, normally the Clearfield Adhesive. I found it very, very effective, and also from research, that has been proven to be one of the most effective adhesives for cervical, specifically for cervical reasons. And then I use, depending on the size of the cavity, 1, 2, 3 layers of flow, but that goes very, very, very fast. For carious lesions, the reason why I make this distinction is because carious lesions might be deeper and they have a different configuration. They have a more critical configuration factor. So if they are a little bit bigger or deeper, I might go with a combination of flow and restorative material. If it's a small carious lesion, I might still use only flow. If it's a little bit bigger, then I might use a combination of flow and restorative material. Clearfield Adhesive, which is a 2-step self-etch system, as my preference. Today, we might say probably also on a case like this, you can use a universal adhesive. Since you come next with the flow, you sort of replace the missing hydrophobic interface. I still believe that the hybrid layer made with a 2-step system might be better than a 1-step, but okay, we don't have really strong data on this by today, so I will assume that maybe a universal adhesive might work here with etching of the enamel for sure. Good. So I hope I could answer your question, Stanislav. Good evening, Stefan. So let's look at your question. How can we replicate the Inspiro shade guides, dentin plus enamel separate with other composite systems? The Stile Italiano only comes up as bonded to one other option, which means tons of different shades. You're right. In fact, let me give you a piece of advice here. When I developed this concept, in fact, I had used it before it became a commercial shade guide. I had developed it for myself with silicone molds. You might fabricate, in fact, as a reference to start with. You might be using even a natural tooth, or you can use a Vita shade tab. And you need to fabricate two physical samples from which you will create molds, and you fabricate your own shade guide. So you will need to get a silicone mold for the enamel. You need to find a way, basically, to stabilize those molds together. It's a little tricky, but there is no way to do it different. Or maybe now, while I'm talking, it's maybe not so easy, but I think it's worth to try. You can use a system, a mold like the one of Stile Italiano, and when you have done the dentin, you isolate the dentin with Vaseline, so that you can maybe separate the dentin sample from the enamel shell, and then you get the two parts of the shade guide. Having said that, I hope it could work if you take a little bit of time to try, but Vaseline isolate relatively well composite from each other. Put enough, but it could work. The only thing that you need to remember is that, as far as I know, the Stile Italiano shade guide, or these molds are made for a layer of enamel which is 0.8 millimeter. So you must be sure that this layer corresponds to your, let's say, to the optimal enamel thickness of the system you work with. Otherwise, you might need to find a way to thicken or to thin your enamel sample. That's the critical point. Because, for instance, with Inspiro, it goes up to 1.5 millimeter. With the one of Stile Italiano, normally it stays below 1 millimeter, which, of course, visually will make a big difference. Okay. Otherwise, there is no mold that we have created around the Inspiro system. But I totally agree with your point. If we want to fabricate all combination of shades, it's very, very difficult. Okay. So I hope I could reply your question in a proper way, Stefan. Now, a question of Joe. Good evening, Joe. Could you repeat the steps of rebonding? Yeah, with pleasure. Before I repeat the steps, let me maybe just confirm that there is a certain timing for the rebonding. And as I explained before, in the past, we will do the rebonding just after finishing the buildup of the restoration. But I realized that when you do the finishing with discs, with fine diamonds, we might still create micro defects. So I found it more efficient to do the finishing with discs and fine diamonds, and then I do the rebonding. Never do the rebonding after using silicone instruments like rubber points, because you will smear the surface with composite and rubber and whatever debris on the surface, and then nothing is bonding anymore. So either after placement or even better after finishing, but not polishing. So the steps are classical approach, etching, so that you de-smear, because if you do some finishing, you will smear the little defects. And then the bonding, this hydrophobic resin doesn't penetrate into the little gaps. So you need to clean everything and open up the micro defects to be able to fill them up with the resin. And then you use your hydrophobic sealer. So you dry, of course, you rinse, you dry, and you apply your hydrophobic sealer. You start like curing, inject the glycerin gel, and it's done. Second option in terms of material, instead of using phosphoric acid to clean the smear at the margins, you can use a self-etch system like the Clearfield SE Bond. So the primer will act as a cleanser, will take away the smear and prepare the surface and the micro defects to receive the bonding. And the light curing is done after a few seconds under glycerin gel, of course. Okay. So, okay, Joe, thank you. Now, question from Koshbu. Good evening, Koshbu. Your question is, can you throw light on, first, what should be the thickness of the liner? So that is what we replied before. 1 to 1.5 millimeter if we use a flow, and it's supposed to be flow. Second point, and during selective etching technique, do you apply a self-etch primer or just a bond for the second dentine layer? Then can we use fiber resin too as a dentine layer? Okay. If we use selective etching technique, that can work with both a total etch or a self-etch approach. So classical three-step etch and rinse. We do selective etching of enamel, and we etch dentine for a different time. Because if you go for 30 seconds to 45 seconds etching of enamel, it's too much for dentin. Why do we stick to a longer etching time for enamel? It's because your restoration will always get micro excesses, overhangs. And if you go for a very short etching time, 15 to 20 seconds might not be enough for non-prepared enamel, because you have this layer of aprismatic enamel on the external part of the cavity. And for instance, if you get little extensions of composite into the grooves of your occlusal anatomy, it will always get debonded and discolored, and that's the place where infiltration starts. So it's really a wrong recommendation, unfortunately, even from manufacturers, to reduce etching time. You cannot reduce etching time below 30 seconds. It's a risk. If you use a self-etch, you only need to etch enamel. Same for a universal adhesive. And then you go with your self-etching primer on the dentin. If you etch the dentin, then you go with your bonding in case of a 3-step etch and rinse system. Regarding fiber reinforced resin material or resin composites, yes, it is an option. It's only for the dentin buildup, as you obviously know. Those materials are a little bit stiffer. They have slightly improved mechanical properties. It's certainly not a bad choice. I would only say that with conventional resin composites, my experience after having done over the last 35 years, thousands and thousands and thousands of those restorations, mechanical properties of usual composites are not a problem. So we had, and we still have up to a certain extent, a little bit of a problem with volumetric shrinkage during light curing, but mechanical properties, even wear resistance, is not a real problem for small to medium-sized cavities, even medium to large, if it is a vital tooth and not below the CG. Again, I think it's a good choice. I'm not really sure that we need much higher mechanical properties. As we cannot use them on the surface, we might lose a little bit the benefit of improved mechanical properties because we cannot use that material on the surface. But it's not a bad choice. Once again, don't take me wrong. You might not really need it. Can you also, and the third part of your question, Kushbu, can you also discuss about desensitizing protocols in deep, large cavities? It's an interesting point. In fact, desensitizing dentin means you plan to fail with your adhesion. So that's what it means. If you don't fail with your adhesion, there is absolutely zero need to desensitize the dentin. Okay, you want to kill the nerves in case you fail with your adhesion. Enfin, kill the nerves, not the nerves, but the nerve, let's say the nervous fibers. But it's something that you don't need to think about. I think you probably think about the Gluma desensitizer because that's the main product on the market. You don't need that. As simple as that. I personally don't want to get glutaraldehyde on my tissues because you apply this on living tissues. I'm not really very. I don't want to say too much because, to be honest, lately I didn't really look in the details about what is the potential or the biology of glutaraldehyde, but it's the wrong solution for the problem we have. If you have hypersensitivity, dentin hypersensitivity or post-op sensitivity after your treatment, it means you failed with your adhesion. So it's not to eliminate the sensitivity, which is the solution. So again, in short, it's something that you don't need at all. Let's be very clear. And if you use it, basically you bring a wrong solution to a problem that you might have. So I think I really don't like the concept because it covers some failures eventually of your technique. So you might think that everything is right, is okay, but in fact it isn't. So you basically you hide the problem you might have. So it's really not a good idea at all. Okay. So I'm sorry. I hope I wasn't too negative, but the reality of the fact is that it's really something that we don't need. There are enough products which we need. This one we definitely don't need. But thank you again, Kishpo, for your good questions. Now, Marco, good evening, Marco. Do you think it is possible, so the question of Marco, sorry, do you think it is possible to build the dentin body instead of 2 oblique increments with 2 horizontal increments, 1 flat and 1 sculpted? Yes, in principle, yes. The research has shown that oblique layers, or what we call also sometimes vertical layers, are more efficient to reduce the tension in between opposing walls. So it's basically just it's based on research. And at the end of the day, it really depends on the size of the cavity. If you are really having if you go with a direct technique in really large cavity, and you are using a conventional restorative material, I even sometimes use 3 or 4 oblique layers. Very rarely, honestly, very, very rarely. But research is relatively well supporting the concept of oblique against horizontal. Good. So thank you, Marco, for the question. Good evening, Hannah. The question of Hannah is, what's the best adhesive system from your point of view? Well, in absolute, the research, if you look at many data coming from research, there is one material that I think every researcher will agree is the best in terms of maximum bond strength and optimal stability. Stability means the limited reduction in bond strength over time. This is the Optibond FL from Kerr. It's also from basically all the research and reports from the group in Louvain around Bart van Beerbeek and his group, who is with his team one of the best teams in adhesion in the entire world. If you take together all their publications, Optibond FL is always coming first, normally. Second one, which is very close in terms of quality and stability, but still aging is a little bit, goes a little bit faster. It is the Clearfield Adhesive from Curare. Those are definitely golden standards. Any modern adhesive system, when it will be eventually evaluated, will have to compete against those 2 golden standards. And just to give you some data, Pascal Magnier had an idea to warm up the unidoses of Optibond FL, because you have little unidoses for the primer and for the bonding. Listen, he could achieve on dentin microtensile 80 megapascals of adhesion to dentin. It is the highest ever recorded bond strength on dentin of any adhesive in the world. If you apply it in the correct way, it's really very, very good. Now, it doesn't mean that all the other adhesives are bad adhesives. Absolutely not. Universal adhesives have some advantages. They are a little bit easy to work with. But if you look for the best of the best, I would say Optibond FL, Clearfield Adhesive. That's even by today in 2020, those are the materials which have the best technologies, the smartest chemistry behind. Okay, good. Okay, I'll just take the last question then, because we are basically getting to the end of our Q&A session. Question of Elena. So the last question for tonight: what clinical situation do you use? In which clinical situation do you use overlay technique? Please tell me if you rebond in the front section. Okay, so it's a twofold question. And there is one last question of Ella before I quit. So overlays there are several indications. Overlays could be used for elevating vertical dimension in two square cases. Overlays can be used to treat non-vital teeth because we want to stabilize the occlusal. We want to keep control of functional occlusal forces, avoid diverging forces, and for this, an overlay configuration is better than just an intracoronal restoration. Or in case the remaining walls are super thin, and that obviously you cannot use an intracoronal restoration anymore. So you need to cover to prevent marginal degradation, or even sometimes if you have little cracks, you don't want to get a cusp fracture, even though that normally never occurs with bonded restoration. So I just summarize quickly. Non-vital teeth elevating video for two square cases, and very thin buccal and lingual walls. And I forgot, together with non-vital teeth, mesiodistal crack tooth syndrome. If you have a symptomatic tooth with a mesiodistal crack, overlay is the only situation. Don't try to go with another approach because you might end up with more problems. Rebonding in the front, yes. Rebonding basically is indicated for any situation, but of course, when you do your final polishing, microtexture, this rebonding layer anyway will disappear from the facial or from the bulk of the restoration. But to do the rebonding along the margins, remember the rebonding is mostly useful to get optimal margins. On the posterior teeth, yes, you can use the rebonding to seal the surface, but I use it mainly, or the core rationale for rebonding is to get better margins. And the very last question from Ella. So thank you, Elena, for your question. And Ella, you've got the last question for you. What kind of antiseptic do you use to treat cavities before restoration? Very simple question, but very interesting one. I would consider two situations. The first one where we use a total etch or etch and rinse approach. By using phosphoric acid everywhere, you don't need to disinfect because you take away the smear, you clean everything. So if you use a total etch technique, no need to use any antiseptic. If you use, let's say, a self-etching system, some people are a little bit worried about the bacteria which remain with the smear layer. Of course, chlorhexidine has been described. It has been shown also to have some interesting properties to inhibit MMPs, which are those enzymes with potential to degrade the hybrid layer. But unfortunately, this action is only short term, so it might not make a huge difference on the long run. Well, some adhesives, like for instance the Clearfield Essibond Protect, also has some disinfectant inside the primer or the adhesive system, so that you might be able to avoid using chlorhexidine. If you use some sandblasting device before you place your restoration, you do your adhesion. It's a relatively common procedure. We could discuss a little bit on dentin according to the adhesive system we use, but I think it's a good method to really clean also the smear. And if you take the smear away, you might leave very little contamination into the cavity. And that brings me back, and that will be the conclusion somehow. If you work with the rubber dam and you start with the rubber dam from scratch, at least you don't have any biofilm forming into the cavity during the treatment. So at least you eliminate any contamination of your surfaces during the treatment. And well, I would say chlorhexidine. Don't use sodium hypochlorite because that is not a good solution to be placed before adhesion. But I would say probably very, very simple: sandblasting or etching, and you will take away the large part of what can remain of the biofilm or bacteria from the decay. And the rest, Mother Nature is going to take care of. Okay, so thank you, Ella, and let me thank everyone who attended tonight. That has been a great opportunity to talk to you tonight. Thanks, Otixident, who brought me to give this webinar tonight and the one last week. I would just like to, after thanking everyone and the technical team who made it this perfect organization, I just hope that I will see many of you in September for this serial of 3 webinars on 2 Square. Be with us. I think it's going to be a lot of interesting concepts and protocols to be shared with you. So thank you once again. Have a wonderful evening. Hope you will have now good time. Maybe you had already the glass of champagne or white wine or vodka during the presentation. Now it's time for me to go and have either a good glass of wine or a good coffee. Bye bye, everyone.